today's session titled The Fourth Wave, Child and Family Health and Wellbeing During the COVID-19 Pandemic. My name is Dr. Jennifer Crosby. I'm the Applied Public Health Science Specialist in Healthy Growth and Development at PHO. I have the pleasure of moderating today's session. Before we start with today's presentation, I'll mention a few housekeeping items. Firstly, the Zoom platform allows attendees to have the ability to customize your own view. You can do so in the right-hand corner of your own screen. Please use the Q&A pod if you have any questions during all of the presentations. We will save the questions until at the end. The chat pod has been disabled to limit any distractions during the presentation. At any point during this session, if you experience any technical issues, please email events@oahpp.ca. We have 4 speakers today: Dr. Andrea Gonzalez, Dr. Jennifer Crosby, Dr. Susan Jack, and Dr. Karen Campbell, who will each be speaking for about 15 minutes. After the presentations, we will have some panel discussion questions, and then we'll be opening it up to the audience questions. It is now my pleasure to introduce our first speaker. Dr. Andrea Gonzalez is an associate professor in the Department of Psychiatry and Behavioral Neurosciences at McMaster University. She is also a core member of the Offord Centre for Child Studies and holds a Tier 2 Canada Research Chair in Family Health and Preventive Interventions. Welcome, Andrea, and I'll pass the floor to you.
Great. Thank you so much, Sarah, and for this, putting together this panel along with all the other presenters, and to Lydia for all of your organizational efforts in keeping us in line. So just gonna start us off here. There we go. So I'm part of a much larger team for all the work that I'll be presenting today. And in part, our work is funded by the Public Health Agency of Canada as part of the Gender-Based Violence Initiative and the Promoting Healthy Families project. In particular, I'd like to thank 2 of my postdocs, Jennifer Crosby, who led the pregnancy study that I'll be discussing today, and Divya Joshi, who was doing a lot of the analyses for the Ontario Parent Survey. This disclosure slide is just related to myself, so I don't have any conflicts to disclose. So it's hard to believe that, we're already past the 1-year mark of when the COVID-19 pandemic started. And in some ways, it's been an unbelievably long year that seems like a never-ending Groundhog Day, and in other ways it's passed, very quickly. But the uncertainty that we felt a year ago remains. But the one thing that's constant is that we need to understand how the pandemic and the shifting public health measures that have been put in place to deal with the pandemic is affecting families and children, especially over time. So this is a graph that I pulled from the Public Ontario Health Ontario website a couple of weeks ago. And this is just to remind everybody that we're now in the 3rd wave here, but our first wave started in mid-March when the World Health Organization first declared the pandemic. Our 2nd wave was around Christmas time, and now we're in the midst of our 3rd wave. The results that I'm going to be sharing with you today from 2 studies is really taking place during this first wave here, from early May, which was almost a year ago today, until about mid-June. And then I'll be presenting some longitudinal studies that will take us up through to the 2nd wave as well. So one of the studies I'll be discussing today is the Ontario Parent Survey. This was a crowdsourcing survey that we launched May 3rd of 2020, so very early during that first set of public health measures where there were stay-at-home orders in effect and all children were engaged in remote learning. We offered the survey in both English and French, and it was mostly advertised through various social media platforms because there was no other way to access families during this time period. And through many of our partners through public health units and children mental health centers and some school boards as well. And we got a very good representation across the province. Some of the data that we collected in the survey, we wanted to sort of represent every level of the family and child and the kind of context that encompassed the family. So we asked for postal code information, which could be matched with material deprivation index information. We asked questions about household composition, so who was living in the household, employment and the impact of COVID-19 on employment and education, caregiver mental health, facets of parenting, and in particular, harsh discipline practices, which is one of the main focuses of my presentation today, family functioning more broadly, inter-partner conflict, alcohol, and cannabis use. And then we asked some questions about child social emotional functioning and changes in child functioning since the COVID-19 stay-at-home measures were put in place again during that initial wave. We had an amazing response rate. So, much to our surprise, we were only hoping to get about 2,000 caregivers, but we had over 7,000 caregivers and parents who participated in the survey with a 73% completion rate of the entire survey. And this represented over 14,000 children ages 0 to 17 across Ontario. But this is only a real snapshot of Ontario families during that initial wave in time, and we are going to be launching a longitudinal component actually next week. So these are some of the demographics of the sample who responded. So the majority were women. It was 94% identified as female. Most were married, so 86% reported being married or in a common law relationship, with only 6% indicating that they were single parents. 89% identified as North American and European ethnicity, 52% had a university degree, and 64% were employed full-time at the time of the survey. So as you can see from these demographics, this isn't representative necessarily of our actual general population in Ontario. This is a more educated and a fairly homogeneous sample when it comes to ethnicity, and a higher proportion of individuals who were married as well. So what were some of our findings? I mean, one of the things that certainly took us by surprise was the percent of people who were reporting mental health symptoms and high levels of mental health symptoms. So we found that 57% of caregivers had elevated depressive symptoms. So this is a screener for depression. It's not a diagnosis for major depression, but 57% were meeting that kind of cutoff, indicating that they had high levels of depression at the time. 1 out of 3 caregivers were reporting moderate to high levels of anxiety. And again, this is extraordinarily high compared to prevalence rates outside of COVID-19. We also asked caregivers about their alcohol and cannabis use in general, and then we asked a question about whether or not it had changed since the pandemic started, and if it had changed, whether or not it was an increase or a decrease. And of those that were reporting that their alcohol level had intake had changed, 37.5% of caregivers were reporting an increase in alcohol intake. And when we asked the same question about cannabis, only a very small portion of the sample indicated that they used cannabis at all in the last 6 months. But of those that were using cannabis and had indicated that there had been a change in use since the pandemic started, an overwhelming, like 87% of caregivers indicated higher levels of cannabis use. So what this said to us was that, people were struggling with mental health issues, and they were using at least temporary coping strategies that would not be helpful in the end. In terms of family functioning, people reported very high levels of conflict with their spouse. So 49% of individuals were indicating moderate to high levels of conflict with their partner and spouse, and 1/4 reported having exploded at their partner or spouse during this time period. And we asked another question about changes in verbal and physical conflict during this time. And unfortunately, that question wasn't separated from verbal and physical conflict, but 10% of respondents indicated an increase in verbal and physical conflict since COVID-19 had started. We asked, very specific questions related to managing, home environments and routines and children's schedules during COVID-19. And parents were reporting high levels of concern for things like managing their child's remote learning, managing their child's screen time and their child's anxiety and stress levels. And about 1/3 were reporting concerns about managing their child's behavior, and half were reporting in high levels of concern for managing their whole household routines and organization and meals. And what's interesting about this is that we're back in the same situation again, with remote learning being in place. And so what would be interesting is, are people managing better, or are they still reporting high levels of concerns across these various domains? I want to just talk quickly about some of our findings in terms of harsh parenting strategies. We found that caregivers were struggling with their parenting strategies that they were employing during this time period. So 1/3 of parents reported high levels of raising their voice or yelling when their child was misbehaving. Almost 1/4 were indicated getting frustrated or angry enough that their child could see that they were upset. 40% indicated that they were being picky or were on their child's back when they were stressed or upset. And 21% indicated getting into long arguments with their child due to misbehavior. When we looked at what factors were associated with these elevated harsher parenting practices, we found that reports of higher caregiver responsibilities during the pandemic was related to higher, harsher parenting practices, lower education, a greater number of children in the household, an increased frequency of alcohol consumption, and greater partner conflict, and higher levels of depressive and anxiety symptoms were all associated with higher levels of harsher parenting practices. But I'm just going to quickly go over some of our preliminary findings for a pregnancy study that we conducted around the same time. We launched this in mid-June, and this is a longitudinal study where we're following women who were pregnant during that initial stay-at-home orders, so in June and July, and we're still following them up now after they've given birth. And it's 304 pregnant women and with 75 partners who participated. And what we found is that during that initial time period, pregnant women were experiencing a range of stressors as a result of COVID-19, including reports of high levels of financial difficulties, less social contact, and increased relationship stress, specifically related to the pandemic. We found across time, so we've now collected 3 different time points, that pregnant and postpartum women have really high levels of mental health symptoms across time. So the darker blue bars here are depression and the lighter blue bars are anxiety. And these are women who would have met that cutoff score that I was talking about. So time 1 was in early June and July, and 57% were indicating higher levels of depression. This continued in our July to December period, and to November to February, after the women had given birth and were at 6 weeks postpartum. Women were also reporting extremely high levels of stress. So more than 80% of women were reporting moderate to high levels of perceived stress across all time periods as well. And when we looked at what factors were related to these elevated levels of mental health, we found that things like financial difficulties, relationship conflict, their own health concerns during this COVID-19 pandemic, and social isolation were all related to poor outcomes in terms of mental health or elevated depression and anxiety scores. We also looked at coping strategies and to see, were there kinds of coping mechanisms that led to more positive sort of outcomes? And what we found was that women who used emotion-focused or problem-focused coping strategies, so things like reaching out to others for support, engaging in kind of humor, or more active coping mechanisms like focusing on what they can do and making plans and strategies on how to deal with certain things and seeking out advice, all led to better mental health scores across time. So what does this mean in general? Stressed out parents equals stressed out children. I didn't talk about our findings in the children, but we do know that children are struggling as well, and that 40% of parents were indicating that their children's behavior and mood had been worse off since the pandemic had started. But all this context of parental stress and interpersonal conflict and parents struggling with their own mental health is setting the context in the home for the child as well. So we have real cause to be concerned here, and that Ontario families are really struggling, and that guidance needs to be put in place and practices need to be put in place to be helping families over time. So what does some of this guidance look like? There are 5 different things that we can start to think about. So one is identifying and developing and disseminating evidence-based resources, so guidance documents, for people in public health, which is something that Susan Jack and Karen Campbell will also be speaking to. Develop preventative public health messaging. So we've developed great messaging around distancing and using hand sanitizer and mask wear, but we also need to develop public health messaging around how do we take care of ourselves, how do we cope, how do we take care of our mental health during this time. Monitoring social needs, whether it's teachers in schools or public health nurses or doctors, family doctors, or whoever comes into contact with families. We need to be asking the questions not only about physical health, but also mental health as well. And then linking families to resources about stress management and coping. We're in a very different position now than we were a year ago, and there's a lot of good resources, a lot of technology that has been employed to maximize, what we're limited to in terms of seeking out interventions and stuff. I know that Children's Mental Health Ontario has a good website associated with different mental health strategies, and then referring the people who need it most to mental and social health services when they need it. So that's the end of my portion of the presentation, and thank you very much.
Thank you very much, Andrea. We're now going to move on to our next speaker. Dr. Jennifer Crosby is a clinical psychologist and health clinician scientist within the Department of Psychiatry at the Hospital for Sick Children. Dr. Crosby is an associate scientist within the Sick Kids Research Institute, Neuroscience and Mental Health Program, and associate professor at the University of Toronto. I'm now going to invite Jennifer to share her screen, and you're up.
Hi all, just getting my screen shared for you. One moment. Give it a second. It's just taking its time. Oh, there we go. There we go. All right. Someone jump in if you can't see what I'm presenting. Okay, so it's lovely to have an opportunity to speak with everyone today. I have the opportunity to share data that has been collected as part of a collaboration at Sick Kids, and I'm going to touch on several data sets that are coming out of the work that we've been doing, and really focused on the impact of mental health in children and youth through the course of the pandemic. So I'm going to walk you through 6 core areas that we've already had an opportunity to look at in this data set. And rather than reading through this list, I'm just going to kind of dig right in because I recap as I go through my talk. So this group of individuals came together very quickly at the beginning of the pandemic to try and capture the impairment associated with what was going on. Quite frankly, I'm not sure we realized how long it would persist, but very quickly this group of researchers pulled together existing cohorts of kids that we were working with who we already had some pre-existing mental health and family functioning data on, so we felt it was a really important opportunity to try to use that data and look across time to see how children and youth and families were doing. The focus was on a real-time monitoring of the impacts of Canadian youth across this time period. So we pulled together 2 clinical samples. So that was utilizing the Province of Ontario Neurodevelopmental Disorders Network, POND, which is a multi-site study, and the Department of Psychiatry Outpatient Clinic at Sick Kids. And then there was 2 community groups. So Spit for Science, which is a large population-based sample that's collected out of the Ontario Science Centre, and Target Kids, which is another community-based sample, both of which had this pre-existing data. And we pulled these 4 cohorts together to really address one key goal. So I'm going to walk you through some basics of the sample, but then fairly quickly get into some data to really hit the high points of what we're seeing in this data set. So although data keeps coming in, for the purposes of this talk, we're looking at a sample of about 2,705 parents and their kids. We have average age is 9.4. Ethnicity is about 62% identifies as European. Income is about 63% greater than 80,000 per year, so a little bit on the higher end. 55% are male. 33% of the group had a pre-existing mental health condition. And 3.5% were reporting some kind of COVID exposure. So one of the first things that we did was some research led by Catherine Cost, among others. And the question was, what is the impact of COVID? What is the impact of the COVID pandemic on children's mental health? This was an initial look in that brief period. And what we found was quite marked. When we asked parents and kids to report how they were doing in this initial phase of the pandemic compared to how things were before, 70% on average across the age range indicated deterioration in at least one mental health domain of depression, anxiety, irritability, attention, or hyperactivity, or OCD. There was some improvement, but they were much less, and this was improvement in one area. So when we looked at what was going on, I'll walk you through this graph because it sort of represents what you're going to see in the next few graphs. The lower bars, those dark bars, are showing deterioration. So that's a reporting of worsening across one of these domains. The sort of mid-level is unchanged and the lighter color is improved. And what you can see here is that we're really seeing marked reportings of deterioration right across these domains, with the highest being in attention, irritability, and mood, but really right across the board, we're seeing quite a lot of deterioration. Similarly, in this graph, I'll set it up for you a little bit here. It's just looking across the age ranges. So blue is parent report and green is child, and it breaks down by the younger age group, 6 to 9, and then 10 to 12. And then for the, we get up to 13 and 18 for in the self-report. And what we see here is, again, right across these ranges, we're not seeing a ton of variability across the ages. You're really seeing this level of impairment associated right across these age groups. And again, this sort of marking this 40%, we're seeing this consistent elevation of reporting of psychopathology across these groups, across the ages. We then had a look across different subgroups within, with a question as to whether or not there might be differences by diagnosis. So the blue is a broad mental health group, includes a lot of mood and anxiety. Green is ASD and other neurodevelopmental disorders. The gray would be a comorbid group, so kids who identified across a couple of different domains. And the orange group are individuals who did not identify a pre-existing mental health condition. And when we look right across these different traits, again, what you're seeing here is that there was quite a lot of deterioration right across these groups. Some of the bigger areas were irritability and attention. These were showing up in, maybe a little bit more in some of the comorbid and mental health and ASD groups, as well as hyperactivity slightly more in the ASD. But one of the things I'll draw to attention here is really that even in the non-pre-diagnosis groups, so kids who did not have a pre-existing mental health condition, you're still seeing quite significant levels of deterioration across these domains. So then we tried to understand what was the impact, what was impacting these mental health outcomes. So what seemed to be the factors that was associated with this deterioration. And by far the main factor was stress from social isolation. So it was associated with the deterioration across all domains. So it clearly was a key factor in what was impacting these mental health outcomes in kids. There was some association with the pre-COVID psychiatric diagnosis, across sort of different domains. And then we did look initially at economic concerns, and there was some indication that for some families there might have actually been some improvement in some domains, but we've really continued to try to understand this and unpack this and some of the other research that we've looked at, which I'm going to lead to next, but I'm happy to pick that piece up in the discussion afterwards. So what was the impact of risk and resilient factors on the course of depression in kids? So this was another review of the data that we did, led by Simone Holligan, a postdoc in our lab. And we looked at both parent reporting of depressive symptoms as well as child reporting of depressive symptoms. And here, what you can see on the left was the parent reporting, and I'll draw your attention to the orange line here, which is the community line. And one of the things about this data was there's not a lot of validated measurement out there across the traits. And this was a really nice way to look at it and to see when we apply a validated measure, what does it look like? And what you can see there is that we actually have a shift right across this group on average of about a standard deviation, which is quite notable when you're thinking about mood scores in a general population group. And they elevated early on in the baseline, and then they continued to be elevated across the time periods. The time periods here were about 1 month apart. And then we look at the child rating. So we use a different measure for self-reportive depression. And this one's really quite striking. You can see there at that COVID baseline levels. This was the early days of COVID. And you can see that the community group is already reporting clinical levels of depression. So this is self-report versus parent report. So on self-report, the youth are identifying themselves within the clinical range, and this clinical level of depression persists over time. So it's really highlighting a marked impact of the COVID. And this is on average. So this is before we start kind of pulling out the factors that are associated with it. When we look at what seemed to be associated with worsening depression, family economic impact was associated, social isolation again, access to services, which I'll touch on a little bit more in a few more slides, a pre-existing mental health diagnosis, as well as factors like sex, age, race, and ethnicity. So in trying to understand what some of the other factors are that are associated, we wanted to see if we could identify pre-existing vulnerabilities to understand what the outcomes were in mental health. So we were specifically interested in looking at material deprivation, so some of the economic impacts. This was led by Jola Rizik, another postdoc in our lab. And what she looked at was a number of factors pre-existing that were impacting on reported material deprivation due to COVID-19. So this was economic impacts that resulted from various measures that occurred because of COVID-19. And she found that child mental health diagnosis, socioeconomic status, and ethnicity of the child were associated with this material deprivation in time one. And these were associated with parental stress, parental mental health, and child mental health, all at time one. And then when we looked over into the time two period, we saw that higher parental mental health symptoms predicted higher parental stress due to COVID-19 restrictions and vice versa. So this parental stress level in time one was associating with parental stress in time two, and that the higher parental mental health symptoms predicted the higher mental health symptoms in both, again, time one and time two. So really highlighting the impact of the stress on the family system, on parents, and on kids, and how this persists across the time periods and how they are impacting on the outcomes. So the next question we wanted to explore had to do with the impact of service loss with the shutdown. I'm going to walk you through some data here. There's a couple of examples, but I'll draw your attention to the highlighted areas here. So this was really looking across our samples. To the far left-hand side, you're seeing some groups, so those without a mental health condition, those with ASD, those with ADHD, and then other mental health conditions. And at the top there, you'll see that I'm looking at in-school services. So this was the loss of in-school services, and you're seeing that 74% of kids with ASD, but 63% and 58% across the other ones, other groups, lost services in-school services. But it wasn't just in-school services that were lost. We see that there was sort of an equally great magnitude of losses in other domains as well. So again, 80%, 57, and 52, so quite high losses across these groups of out-of-school services. And this isn't just academic, but this is also social work and speech language and the other elements that happen in school. Similarly, we see a loss here of resources and access to medical services. So 58%, 48, 41%. So this was kids who lost access to medical care in the early phases of COVID-19. And then we look at what the impact is. And this is just an example of the data. We're really starting to just look through this data set, but it's showing that for when we look at internalizing symptoms that are associated with this loss of medical service, you're seeing a significant increase in the internalizing symptoms for those who did lose their medical services, as well as the externalizing symptoms. When we look at academic learning losses, so access to academic services, we again see these association with internalizing symptoms and externalizing symptoms across the groups that we are looking at. This work, was pulled together a model to try to understand what the impacts were. And I'm going to simplify it for you slightly. But what we see here is that the service loss negatively impacted all aspects of mental health by contributing to COVID-related stress in both the parents and the children. So by this pathway of service loss is impacting the stress overall with the children and the parents, and this is causing significant impact across all of the domains that we looked at with regards to children's mental health. So the last section I'm going to highlight today is work done by Zuli Lee, and it's looking at the impact of screen time. So this is broken into two age groups, given the data that we have. So in the initial younger group, so this is the target kids cohort, the mean age was 5.8. You can see there a breakdown of the kinds of reporting of screen time that existed, with most of it being sort of digital TV media, but across the other domains as well. Not surprisingly, in this younger age group, social media time was less. So on average in this group across the domains, about 2 hours of screen time per day, but that was on average. As you can imagine, there was quite a bit of variation. And the impact of this screen time was quite severe. So overall, with an increased screen time, there was significant association with irritability in children aged 2 to 11 and significant increase in hyperactivity in children 4 to 11. Video game time was associated with increased hyperactivity in children ages 4 to 11, and e-learning was associated with increased hyperactivity in boys 4 to 11. So in this younger age group, even with, you're seeing these significant impacts across these domains, across different types of screen time. Then it was looked at in our slightly older cohorts. So this is the other 3 cohorts within this sample. And what you see here is that these kids were ages 5 to 17, so a slightly different profile of TV watching. And you see these significant negative impacts, but in slightly different domains. So for e-learning, we had significant increase in depression and anxiety. For TV and digital media, significant increase in depression, anxiety, and inattention. And for video games, you can see these significant changes right across depression, inattention, irritability, and hyperactivity. And there was a hypothesis or an idea that perhaps the face-to-face time, the socializing, the part where you get to interact with your friends might have some sort of protective element, but we did not see a protective aspect of the face-to-face screen time. And I'm not going to go through this table because it's quite busy, and these results are still in early days. But one of the things I will show you here is that, you know, the significant results are being shown quite early on here. So, you know, past 1 hour, but even when you get to 2 to 3 hours in screen time, you're really starting to see these significant results, even after adjusting for a range of factors such as previous diagnosis, child and health, ethnicity, family income, parental mental health. So even after adjusting for a range of factors that might be associated with some of these outcomes, we're still seeing significant results that are quite profound. So what's the summary of this data? And I know it's been a bit of a whirlwind, but I think some of the key themes really do come through, that children are really struggling. So 70% of children reported worse mental health. Stress associated with social isolation comes up repeatedly and was the largest predictor of the deterioration. Depression increased and has not gotten better, so it's persisting over time. We have kids who weren't depressed before that are now depressed, and they're staying there in the clinical range. Sort of a range of pre-COVID socioeconomic and mental health vulnerabilities have led to increased parental stress, and decreasing mental health outcomes for kids and parents. Service loss was high across areas, impacting a range of children, and pre-existing mental health and neurodevelopmental vulnerabilities increased the negative impacts. The increase in screen time is having a significant impact on our kids' mental health, and it's right across the different types. So these are each individual screen time, but then they get added together, and it's really very important that we start to understand that and understand the negative impact. And when we think about, you know, we'll talk about it at the end, but when we think about what needs to be done, I think there's a range of factors we can talk about, but we need to be thinking about parental mental health and services that are tailored to children and parents and families, but we really need to soon be acting to optimize those outcomes. So these are just some images, some of my own personal images of my daughter through COVID, her learning. This is her waiting to get a COVID test so she can go back to school, and just a reminder that how much of children's lives have been shut down in the context of the pandemic. We had a range of funders and supporters that facilitated this work, both institutionally and funding as well. So with that, I will end.
Thank you so much for that, Jennifer. That was really impactful, and there's a lot of data there. So moving right along, our next speaker is Dr. Susan Jack. Dr. Susan Jack is a professor at the School of Nursing and associate member of the Department of Health, Research Methods, Evidence, and Impact at McMaster University. So go ahead, Susan.
Great. Thank you, Sarah. So good afternoon, and thank you to Public Health Ontario for this opportunity to share some highlights with all of you from our environmental scan documenting how the COVID-19 pandemic has impacted Ontario's public health home visitation programs. And it's really my pleasure today to be the one to present these findings on behalf of the Public Health Nursing Practice Research and Education Leadership Team. That is an amazing collaboration between public health partners, researchers, and project and knowledge mobilization staff. And I'd also like to acknowledge that this work has been made possible with both the funding and support from the province of Ontario. So for those of you on here who are not affiliated with public health units, just a bit of a summary that all 34 public health units in Ontario are required to provide the Healthy Babies, Healthy Children program services during the prenatal period and to families with children from birth up until their transition to school. And the overarching goal of the HBHC program is really to optimize newborn and child healthy growth and development, and to reduce health inequities for families who are receiving their services. And program elements of the HBHC program include universal screening at the time of birth, ongoing assessments, referrals to community services, service coordination, and really one of the hallmarks of the program is the delivery of a blended home visiting program where both public health nurses and family home visitors provide health promotion supports to families and children. In addition, 5 public health units in Ontario offer a program called Nurse Family Partnership. And this is a targeted home visitation program specifically for young first-time mothers who are experiencing significant levels of social and economic disadvantage, and where public health nurses start visiting families early in pregnancy, often around 16 weeks gestation and no later than 28 weeks gestation, and continue to visit families frequently until the child's second birthday. So we conducted an environmental scan to understand how the COVID-19 pandemic has impacted the delivery of both the HBHC and the NFP programs between March and December 2020. And we only required one response to the survey from each program. And during a period of really tremendous uncertainty and constant change, we were so grateful to the teams for completing this work. And we had a 100% response rate. So thank you to all of these programs and for returning surveys from the 34 HBHC and 5 NFP teams. So what did we find? The first one is that, of course, public health units across the province have been responsible for providing immediate and ongoing leadership to manage the pandemic. And this has meant internally within public health units, there have been a need for increased human resources to assist with such COVID-19 activities as case management and the implementation and delivery of vaccinations. So as a consequence of these shifts in human resources, 97% of the HBHC teams were required to redeploy public health nurses from their teams to work in other teams and other departments. And among these teams, most of the health units, 70%, reported that more than half of their workforce were redeployed to this other programming. Now, the impact of these redeployments meant that services to families have decreased. There was a significant reduction in home visits, and there's a limited capacity for nurses to complete their in-depth assessments or to provide ongoing nursing supports. The HBHC nurses who did remain in the program subsequently saw their caseloads numbers increase significantly. They increased their reliance on family home visitors to connect with families as appropriate. And they were required to begin to triage what services could be offered to which families at a different dose. What we did learn, though, was that in many health units, there was a very strong commitment among leadership to delivering some level of continued programming to families, and in particular, a recognition to prioritize the limited remaining resources to provide services to families who were experiencing significant health and social challenges, including mental health issues, child growth and development delays, intimate partner violence, and those families who were engaged with the child protection system. There was a very clear message that we heard from some health units that they sought to position HBHC and NFP programs to families as an essential component of public health's response to the COVID-19 pandemic. And in the 5 health units that offer the Nurse Family Partnership Program, the rationale for limited deployment of nurses to other programs was that their senior public health leadership supported the prioritization of continuing delivery of this program, which serves clients who are amongst the most vulnerable served by public health. So for the public health nurses, though, who remain to provide these home visiting services through the HBHC and NFP programs, the COVID-19 pandemic created new stressors and challenges. Over 90% of health units reported that nurses were experiencing increased stress levels specific to the pandemic. And these stressors were often related to the intersections of their personal and professional lives, associated with the rapid transition to working from home and stressors in securing ongoing childcare. Other stresses we learned about reflected concerns about potentially contracting the virus through in-person home visits, or alternatively, concerns about contracting and then spreading the virus to other individuals. With increasing stressors, almost 40% of the health units reported that the transition to virtual work then subsequently limited their ability to conduct high-quality reflective supervision with staff, a valued source of support for their nursing workforce. Now, a valued and really important element of both the NFP and HBHC programs are the face-to-face encounters with families through in-person home visits. However, efforts to limit the transmission of the virus required public health nurses to simultaneously shift from in-person visits to alternative methods of meeting with clients, and for many, the shift to working from home. 60% of health units did not permit their staff to come to work in the office, except to come in briefly for administrative purposes. And with the implementation of public health measures, when asked about current policies regarding in-person visits by HBHC nurses, almost 77% of public health units indicated that they required or recommended the reduction of in-person home visits. And 80%, or 4 of the 5 NFP programs, also required that their teams reduce the in-person visits. So in my 26 years of working in different facets of public health nursing practice, education, and now research, one thing that I've learned and have always valued is how flexible and adaptive public health nurses are. And this is illustrated in the different ways that they found to connect with the families. In the HBHC program, as well as we can see similar trends in the NFP program, health units estimated that approximately half of their contacts with families were now by phone. About 20% of contacts occurred through video conferencing, and just 22.5% occurred in person. And when those in-person encounters occurred with families, almost half of those continued to be conducted in the client's home. However, nurses and families creatively found other spaces where public health measures of physical distancing could be adhered to. And they conducted visits in parks, in other outdoor spaces. We heard a lot about walking visits, as well as many nurses arranged what we commonly heard to refer to as driveway visits. So meeting families outside of their home on a driveway. Now, like many of us, home visiting programs rapidly transitioned to providing some program services through interactive video conferencing. And we heard from teams that it was challenging to onboard to virtual video conferencing. And different platforms are used by different health units. There were limitations placed on nurses in some health units on even which platforms they could be using. And access to training and technical support or even reliable internet connections was limited in many places. And it was also challenging for clients, with the majority of programs 84% of HBHC programs and 60% of NFP programs, indicating that their clients' access to technology, to phones, to data, to tablets, to computers, to reliable internet, really impacted the ability for nurses and clients to consistently connect and communicate. And while in this environmental scan, we did not collect data directly from clients, the programs were able to share with us what public health nurses had learned and had heard from the families they serve. And almost 2/3 of health units reported learning that some families they serve are uncomfortable with virtual home visits. A similar number of health units shared that they connected with families who were not interested in virtual home visits. And almost the same number of health units indicated that there were families on nurses' caseloads who do not have safe or private spaces in which to conduct a virtual visit. And this is a critical safety issue for nurses who may be working with a woman experiencing intimate partner violence and isolating at home with her partner. So there were also challenges for nursing practice. Changing the mode in which nursing care to families is delivered from in-person to virtual created significant challenges that limited nurses' abilities to safely and effectively assess for and respond to such issues as intimate partner violence and mental health concerns. A majority of the health units, and again 97% of the HBHC programs, reported that nurses experienced significant challenges in completing their required nursing assessments of parent-infant attachment, and both nurses and family home visitors found it difficult to provide interventions such as the PIPE program to promote safe and sensitive parenting. And the move to virtual visit also impacts the retention of families in these programs, with 3/4 of the HBHC programs and 100% of the NFP programs reporting that virtual visits impact client engagement. But it's not all doom and gloom. So despite these challenges, there were some benefits to virtual visits that were shared with us. The teams reported that some families really appreciated not having to clean their house and get the house ready for a family home visitor or a nurse to come for a visit. That many families now had increased confidence to reach out to a nurse through phone or text between visits. And for many clients, virtual video conferencing and texting is really their more commonly used form of communication. And for these clients, nurses shared that they were actually more chatty when they were allowed to text or to call them compared to the more formal conversations that happen in the home. And for public health nurses, there were some benefits. Some found that with decreased travel time, this allowed for increased availability to connect with more clients. They were able to connect with families who were hesitant to have a public health nurse come out to their home. And there was also increased flexibility for scheduling visits. And we learned about many new innovations that arose out of this changing context of care. We learned that different health units took this opportunity to develop virtual service standards. There was an increased sharing of resources and collaboration between health units, as well as between health units and their local community partners. And we heard examples of many new initiatives, such as the development and piloting of virtual support groups for families, as well as new opportunities to develop individualized options for service delivery to meet the unique needs of each family. So what are some of the key points of reflection to take away from these findings? First, as we prepare for the fourth wave of the pandemic, given our increased understanding of the impact of the pandemic on child, maternal, and family health outcomes, it is critical that home visitation programs are prioritized and positioned as an essential component of public health's response to the pandemic, and that future deployments of staff from these programs are stopped or minimized. And given the complexity of the issues that a greater number of families are experiencing, it is critical that the public health nursing workforce is provided with the necessary professional development and resources to continue to assess for and intervene to support families experiencing issues such as mental health, substance use, challenges with infant attachment and parenting, and intimate partner violence. We also know that from past research in the literature that there is a connection between client retention and nurse retention. And the nurses that are going to be returning to the Healthy Babies, Healthy Children programs may be experiencing unprecedented levels of stress burnout, and exhaustion. So it will be critical for health units to prioritize and recognize the importance of addressing nurse wellness, prioritizing regular reflective supervision, and creating space and opportunities for teams to debrief and to connect. And finally, the shift to the virtual delivery of services created both challenges and opportunities for families and nurses. Moving forward, it will be valuable for health units to give consideration to how a range of service delivery modes can be made available to teams. But this will only be successful with appropriate levels of training and technical resources and texting and communication policies aligned with contemporary nursing practice. With this shift, it will be necessary too to focus on prioritizing options and flexibility, leaving the decision whether a particular visit is done by phone, text, or Zoom, or an in-person connection up to the nurse or family visitor and the client. So this is just a brief highlight of our findings from the environmental scan. A full report of all the findings is available on our PHN Prep website. Thank you.
Thank you so much, Susan, for highlighting such an important part of our public health work, especially in healthy growth and development. I'd now like to invite our last but not least speaker, Dr. Karen Campbell. She's a postdoctoral scholar at Western University, Arthur Labatt Family School of Nursing. She completed her Master of Nursing at Ryerson University and received a PhD in nursing from McMaster. Dr. Campbell has over 20 years of experience as a registered nurse. Go ahead, Karen.
Thank you. I'm going to jump right into this. Up to this point, we've heard about the multiple challenges that families are experiencing during the COVID-19 pandemic, and we've also heard about the pandemic and the impact of that on home visiting programs from the perspectives of managers. I'm going to shift to the voices of the public health nurses that are continuing to deliver healthy babies, healthy children, and the nurse-family partnership programs in Ontario. Between November 2020 and March of this year, we conducted 11 focus groups with 46 nurses from 18 health units to understand more about the complex situations of the families enrolled in these home visiting programs and to elicit the nursing practice strategies and solutions that are being used to address these challenges. These are the stories from those public health nurses. New parents often rely on their community of friends and family around them. These supports and even community services were not readily available throughout the last year. For public health nurses, this meant that there were less available or accessible community resources to refer clients to, but there was also an increased need from clients to be referred to services. So they were finding that new parents, when they were unable to create their social networks and see a range of childhood development and activities, they were seeking out referrals that potentially were unnecessary as a result of their own heightened anxiety. And this meant that nurses were required or had to help them to monitor children's development and also to address parental anxieties. Referrals to the HBHC and NFP programs decreased at times. That was partially because many community providers made assumptions that these home visiting services were on hold as many public health nurses were redeployed to the pandemic response teams. So there may have been less referrals because of that. There was also services that were closed that were normally sites which would refer into these home visiting programs. And there were also nurses, public health nurses, who act as hospital liaisons between the hospital and these programs that were no longer entering into the hospitals. There were barriers such as clients that were living in shelters where they couldn't be reached in person because of visiting restrictions. And they also didn't have options for virtual because they lacked a personal computer connection. Language barriers continued to be a challenge in many communities. And also being able to access free services for families was really challenging, especially whenever they were barely able to afford their groceries and rent. Despite the reduction in referrals, there were increases in wait lists for these programs, and nurses were really surprised to see how eager parents were whenever they started to open up those wait lists, and they were reaching those parents who really wanted to be part of the programs. Nurses' caseloads have varied throughout the pandemic. Early on, some of their caseloads had doubled the normal amount of clients that they would see as they attempted to take on caseloads from their deployed colleagues. At other times, they were discharging clients quickly who they probably would have otherwise allowed to remain in the programs. And most recently, they reported that they're actually reaching out to parents at that 48-hour phone call and just getting this gut feeling that they should continue and follow up with this client. And most often their hunches were correct. So rather than discharging them right away, they'd hold on to those clients. Overall, across all of the nurses that we spoke to, we heard about the increase in the complexity of their clients. One longtime Healthy Babies, Healthy Children nurse told us the risk and the acuity is higher than I've ever seen in my duration of being with Healthy Babies, Healthy Children. And it's pretty common with nurses when you sit and talk. It's hard to maintain your own self-care and prevent vicarious trauma from really getting to you when you're feeling isolated and unable to connect with peers. But despite many health units not having an open office space, these nurses really are creative in how they attempt to maintain connections with their team so they can support each other as they navigate how to work in this new environment. They also heavily relied on their managers, who sometimes were inconsistent as they would cycle in and out of the pandemic response. But these relationships between teams, as well as with their managers, are highly important to them as they learn how to function in this space and to retaining nurses. Public nurses did not have a shortage of really intense and emotional stories to share with us. Some were extremely difficult situations that were typically seen in larger cities, such as nurses that were working with homeless populations who in pre-pandemic times would meet pregnant women on the streets, make connections into the hospital. And now they're hearing that those same women are now delivering on the streets because they haven't made that connection. Other stories were very common, especially those around food insecurity. Breastfeeding, for example, is one method of ensuring that infants are getting a healthy start to life. It was quite difficult to provide support for over virtual connections. So nurses have orchestrated tips and tricks in order to virtually do this and find safe ways to meet with parents. But as anybody who's breastfed a baby or helped somebody support a baby, you can imagine how difficult that was while mothers are trying to latch a baby and hold a phone. Many health units have a dedicated nurse doing this, but it's also challenging for nurses to help parents identify feeding cues without being able to see the babies clearly. Not surprisingly, economic difficulties have led to an increased reliance on food banks. Food restrictions and fears about being exposed to COVID made accessing these supports difficult for many families. Many nurses who were working with parents of toddlers found that they were experiencing food aversions. And we might know these as picky eaters, but when this is happening within the context of food insecurity, parents and nurses were really starting to worry about the health of children. And one nurse told us about a toddler who she had suggested to take to the hospital, who was then transferred from a community hospital to a large children's hospital. And when she came back home, the child was vomiting all over his clothes, and she quickly ran out of laundry detergent. In situations of high stress like this, the coping mechanisms were really decreasing. And it's these basic things that parents are finding difficult. Just problem solving was a big challenge, and trying to figure out, how is she going to do this? How is she going to get laundry detergent with 3 kids under 3? One's vomiting completely, and the grocery stores aren't allowing her to bring the other 2 kids in. And the older 2 don't want to keep their masks on. But her nurse was helping her to move through these challenges. Just being there. And she said, just being there with our goggles, our masks, our gown, and we're sitting on a stool, but they're just happy that we're able to visit. Another common challenge was with daycares and schools being closed or having changes to their restrictions. More children were at home, and parents were finding it challenging to provide food all day long. Daycare was a good way for the kids to get 3 solid feedings. They could have 2 snacks, have their lunch, and they're good to go. So maybe mom could take a bit of a back seat when it came to dinner time, soups, be creative. But now they're feeding kids all day long. It means that we have to stretch what little they have even further. Overwhelmingly, we heard stories about public health nurses assessing for perinatal mood disorders. One nurse said that their depression and anxiety assessments were just flying off the shelves. Other nurses told us about having these assessments close to them whenever they were connecting by phone or by computer because they knew that they would need them. They reported a huge influx in moms who were suicidal and doing a lot of infanticide risk assessments. Because of financial difficulties in accessing services, nurses are really taking that main role in supporting maternal mental health. It's important to note too, the number of nurses who determined the need for an in-person visit despite COVID restrictions, and then ended up referring a client directly to the hospital. And in most of these instances, nurses believed without that face-to-face contact, it's unlikely that that connection would have happened. In one example, and it wasn't the only example that we heard, but in one example, during a phone call with a nurse from a nurse family partnership program and a client, they determined that an in-person home visit was needed based on the nurse's assessment. And during the in-person visit, the client did share that she was having suicidal thoughts and initially refused to seek any help. The nurse was able to support the client, get her to the hospital, meet her at the ER, stay with her during the intake process. The client was admitted to the hospital to receive medical care and the support that she needed. Though it's not the only scenario like this, it is likely that this could have potentially saved this young mother's life. Public health nurses are skilled at developing those therapeutic relationships with clients who otherwise may not be willing to interact with other social service providers for a variety of reasons. A lot of my clients are very service shy is not something that was unusual to hear. Public health nurses have long-standing relationships with these clients that allow them entry into clients' homes and lives. One story that really stuck with me was from a nurse who took a nursing student with her to visit a family during the pandemic time. The family had 4 young children in the home, and like many of us, they got a pet during the pandemic. So now there are kittens. And when she got there, there's also litter all over the floor, feces everywhere, a 6-month-old baby who's ready to start crawling, and no floor space. There's a toddler who's fecal smearing, so there's feces on the walls, on the floors, on every surface. And the parents are just so defeated. They're at the low end of their coping spectrum. And with all the extra stressors and 4 kids being at home, they're just having a hard time addressing the basic needs. The nurse can't even sit down, so she stands and has a conversation and looks for strengths so that she can build a rapport before she says, hey, we need to start washing the walls, because she knows. And she immediately starts her nursing assessment, understanding the significant signs of developmental delays and disorders that she's seeing with this toddler before she even broaches the subject of, is this a potty issue? She says she's assessing for developmental issues. And she says, there's really something important about the work that we do as registered nurses for setting those goals with complex families. If you're still unsure about what public health nurses do, here's how they describe it. Right from our first interaction with the client, we're building rapport, the active listening, the mindfulness that we are providing the client. It may not seem like we're doing much, but what we're doing is using guiding questions that allow us to paint a better picture of the whole situation. And we do this looking for strengths, using a strengths-focused approach, even from the first moment of meeting them. Oh, look at how excited your daughter is that you made this strawberry meal for her and you put that together for her. And that's great. And way to go, Mom. And that's not something that these nurses just do innately. It's something that they've learned to do. It's something that they've been taught and trained to do. And again, it follows nursing theory. We're going through all of these stages of planning, assessing, listening, acting, evaluating every outcome of every intervention that they provide. And if the outcome isn't what they were expecting, then they stop, they ruminate, they reflect on how or why, and then they switch those things up to address the next need. It's a science, it's an art, but it is nursing. The response from families is that they overwhelmingly appreciate and value the support that they've received from their public health nurse, especially during the COVID pandemic, when supports were really limited or non-existent. When nurses are calling new parents for a 48-hour postpartum phone call, the response and receptiveness is high. Parents are craving contact with knowledgeable health professionals. And clients are increasingly, probably like most of us, becoming more open to meeting over virtual modes. And like Susan mentioned, some nurses are even finding that this is a more effective way to begin to build a relationship with some mothers and parents that may be unlikely to let them into their home or the place that they're staying, which might not even be their home. Public health nurses are really feeling the gratitude from families. We're just finding that they're grateful to have us there, 6 feet with our mask and our shield, to just cry and say, what are we going to do next together? They're just grateful to know that there's a service that's still providing a service, as opposed to, here's your wait list, we'll see you in 6 months, maybe. If I could leave you with 3 takeaway messages, these would be that public health nurses play a critical role in supporting families' health and well-being, and we need to make efforts to protect this workforce because this will affect the health and social needs of families. As public health nurses are reintegrated into home visiting programs, we need experienced, skilled nurses who can remain in the program for the duration. They need to be oriented to the new ways of interacting with clients and prepared for the increased acuity and complexity. Maintaining competency in their area is important, and the constant movement between pandemic responses and home visiting is really taxing on nurses. The Healthy Babies, Healthy Children and Nurse Family Partnership public health nurses across the province are committed to delivering complex nursing care to families and require organizational support, high quality supervision, and opportunities to debrief and connect with their colleagues to support their own health and well-being. And I'll leave you with this one quote that sums up how universal these experiences were for nurses. She said, "We're all in this together. We're in different cities, but we're having very similar experiences." Thank you. Thanks for listening. Thanks to the public health nurses who shared their story with us.
Thank you, Karen. That was wonderful. So important to have the stories on the ground. I'd like to invite all the speakers to share their videos and unmute. We're going to thank you all for such excellent talks. Feel a little bit overwhelmed by the amount of data that we saw. My fault, I scheduled all 4 of you on the same day. But I think it's so important because what you've shared with us, I think all of us on the line and in Ontario have been feeling this, and having the empirical data to support it is really critical. I'm going to start off the discussion by asking all the speakers a question. So what are the most critical changes that we need to make moving forward that we haven't been doing that we can do to support these children and families? Go ahead,
I'll jump
Jennifer.
in. I think that it's really critical that we figure out how to get kids outside and active and socializing. The social isolation is having devastating effects, and the corollaries of that, the excessive screen time, all of it, and the longer it drags on, the worse it's going to be. So I think really there needs to be a focus on how we get kids outside and active and engaged in person safely with other kids. And so I think that needs to be a priority.
Thank you. Anyone else have comments?
I could just add to that, like I had mentioned in my talk as well, that just adding to what Jennifer said, that there is an increase or a heightened anxiety or of parents whenever they're not socializing with other children as well. So not being able to see that normal, healthy development is increasing the anxiety of parents who then that's then being put on to other children whenever they've got other older children in the home as well. So I would agree with that.
Thank you. My next question is for everyone, but for Andrea, based on her parent survey. Parents, specifically women, were not adequately supported during this pandemic. So what would we do the next time? What supports could be given now and should be given in the future?
Yeah, thanks for that question. I mean, we've heard through various sources internationally that women in the workforce have been incredibly impacted by the pandemic and having to balance home and life. So I think part of the challenge is putting some understanding, I guess, even in the workforce, that employers really need to understand what caregivers are going through right now. I say women, but men have also, taken responsibility for caregiving and needing to do some of the balancing act as well, and that there needs to be just more understanding and a lot of flexibility around that. I think some employers have done it, and that's fantastic. I think some have been flexible in terms of options around hours, but what ends up happening is these caregivers end up working at night and never get a break themselves. So then they're feeling burnt out, which does not help the situation at all. So it's really, I think, just lessening expectations and workloads and trying to be supportive around that. And then, having maybe guidelines, similar to what Jennifer was talking about. We need to get out. How do we interact with our children in positive ways? How can we get away from screens and get outside, especially now that our weather is better? It was really nice to see that they lifted that playground restriction, because we found in the Ontario Parents Survey that one of the positive experiences that parents certainly listed was getting out in nature and doing more things with families. So it's giving families strategies on what are some of those kinds of positive things you can be doing, and just getting outdoors more and being more physically active. So, yeah.
Thank you. I'm going to take an audience question. Thank you so much for identifying the crucial role of supports for families during public health emergency response. What do you feel can be done to have this work better represented in emergency management and pandemic planning going forward? I'm thinking of some of the key things mentioned, like establishing the priority of communications among PHNs and managers providing services, as well as prioritizing particular services.
Yeah, I can start this one, and thank you for that question. It is a difficult and challenging question, particularly as it relates to human resources within organizations. And I think now, within the year, there's been a lot of experience within the health units, a recognition of what is needed. And moving forward, one of the things that I've really, I think, reflected on recently is when we're thinking about priorities and shifting human resources within public health, who gets moved is an important consideration. And the supports for families through the provincial programs, these are relationship-based programs, and nurses invest a lot of time in finding families, establishing those relationships, nurturing them, using a lot of strategies for ongoing connections. And anytime there's a disruption to those therapeutic relationships, it creates more stress for families, and it creates disruptions, to addressing families' needs. So looking forward, as other, in pandemic preparation and management of other issues of case coordination, case management, vaccination, important to look at what other, program skills or tasks are more task-oriented rather than relationship-based, where other individuals can be trained to deliver that. So I think really asking the question, if we're going to disrupt programs or services that are based on relationships, maybe we don't do that immediately. And are there other individuals within the health unit or external to the health unit that can be trained to do some of the more task-oriented requirements within the pandemic response?
Thank you. Great answer. I have another question from the audience. I'd like to know more about your thoughts on the negative effects of COVID-19 on more vulnerable communities, such as Indigenous peoples and visible minorities.
So I can talk a little bit. Our sample thus far does not have sufficient representation to look explicitly at Indigenous populations. We did have an opportunity in some of our analyses, and we will continue to look across individuals who identify in as sort of non-European or minority groups, and we have seen some association with those groups and a number of the negative outcomes that we've been looking at. So it's an area that we're hoping to dig in more and to get a greater understanding, and some of the ideas around what were some of the pre-existing vulnerabilities that made people at greater risk for experiencing some of the negative outcomes associated with COVID-19. So definitely across some of the data that I presented, I highlighted where we had been able to look at that explicitly, and it did come up several times as a factor. And perhaps as we get more data over time, we can continue to look at those factors and more explicitly talk about what factors moving forward will be helpful to identify people who are at greater risk and then support them, and really sort of be sort of one of our next phases is to actually look within our groups, try to identify pockets of individuals who seem to be at higher risk, and then thinking about what kinds of targeted interventions would be most helpful for them. For this group, because this pandemic just keeps dragging on, so I think there's still scope for that, but also for future exposures of these kinds that may occur.
Thank you. Anyone else have a comment on increasing data collection for marginalized communities?
No, not to add much beyond what Jennifer just said, except this is really a group that's underrepresented in any research. And we know from the data that we have collected on more middle class or higher income families that these risk factors, which have been exacerbated during COVID and financial risks and stuff, are driving some of the mental health findings that we have, and that one can only imagine that it's probably even higher in these groups, and it's just, we really need to be better at reaching them and putting more services in the areas that we know are hotspot areas, not only related to COVID, but our marginalization index map onto these hotspot areas, because these are people who are frontline workers and that they work in, they can't stay at home. They don't have the luxury of staying at home and working from home. So they're out there and having to go to work and then have those stressors at home with their kids, with the remote learning and everything else going on as well. So I think if we could be targeting hotspots and offering more social and mental health services in them as well, that's something that needs to be done.
Yeah, and I think the other point to that is that while the pandemic has put a spotlight on that, I think the vulnerability is there regardless. So any services that are put into build resources and provide support are going to be beneficial regardless. Yep. The pandemic just sort of unveiled how precarious some individuals are, and that adding this massive stress has really been highly problematic. Yep.
Thank you. Our next question is, I would like to hear if there are any anticipated mental health challenges for families, parents, and children anticipated with the post-pandemic recovery. I'm wondering about how the return of schedules, being around people en masse, the return of social norms might also cause anxiety or stress.
So I'll say yes. I think we don't have the data, of course, we don't have the data yet. But most definitely, we're talking about families and kids now who all of this data has shown just how devastating and the negative impacts. So, and now we're over a year into this. So, we know that getting those individuals who were struggling in this period and getting them sort of the resources they need and back on track is going to be difficult before you even factor in things like academic delays and all those kinds of elements. But then on top of that, you're going to have a new wave of kids who may not have struggled during this period. There is a subset of kids who managed and maybe, the less socializing and, the reduction of some of the activities and sort of a minimization or an increase in structure was helpful. But yes, so you're going to have this additional group of kids who potentially are really going to struggle as we try to get back into the routines and the schedules. So I think that we can anticipate that, if anything, it's going to sort of add a new layer of kids and youth and parents who are going to struggle in a new way. Yeah.
Thank you. I'm wondering if this is another question from the audience. I'm wondering if this data will help develop future program supports for HBHC staff in terms of mental health training, or if there's any talk about education for PHNs when picking up the pieces of the pandemic. I'm going to guess this is to Karen and Susan.
I think this is critical, and certainly in our environmental scan, we did ask what are priorities for guidance and education, and mental health, responding to mental health, intimate partner violence. Typically, we're at the top of the list of topics requiring additional support. So it's looking then at what are the mechanisms of our team or different teams working together with the health units to start to identify what are those specific education needs and how best can they be met. And certainly in my work around the province, I think there's really an awareness of this need, and now it's just thinking about how is that accomplished. So it's on the radar.
Karen, do you have anything to add?
Add that we're also looking at setting up communities of practice and looking into what other standardized education that we can have across the different programs, across the different communities, so that all communities have that across the province.
Great. Our next question is, I think it is increasingly evident that we should expect increased prevalence of adverse childhood experiences. Maybe the pandemic itself is an ACE. I've heard that too. This is a global trauma. What are your recommendations for an ACEs-informed approach to pandemic recovery?
Yeah, and another great question. And without getting into the debate of how do we identify ACEs and what's an ACEs, I think some basic principles maybe to take into consideration moving forward that probably the pandemic will be experienced as a source of trauma for many families or children. And so how do we begin to ensure that the first thing that the programs themselves adopt and embed principles of trauma and violence informed care, both at frontline service delivery and at the organizational level. And then for programs and teams to begin to think about what are the structures or assessment tools, I don't even want to say the word screening for ACEs, but some sort of mechanisms within the programs that allow nurses and family home visitors to give families an opportunity to talk about what has happened to them. And then for nurses and family home visitors to explore and reflect with families what have these experiences over the past year, what impact may they have on their health, right? So normalizing and saying, we recognize that these experiences are playing a role in your mental and physical health outcomes. And then more importantly, or equally importantly, I think having the tools available then to talk about what have been positive experiences throughout the pandemic and what are tools available for supporting families to develop resiliency. So do teams, NFP or HBHC teams, or any programs across the province, do they have tools and resources to talk about resilience building and building strengths? And then, because I come from a public health perspective, it's also looking at primary and secondary prevention. We know that there's been many, what they've called intersecting pandemics, right? So increases in mental health, increased rates of intimate partner violence, You know, I haven't seen the data, but we might anticipate that there's increased rates of different experiences of child maltreatment. So also having resources and supports available, again, for professionals to be able to focus on primary and secondary prevention of those issues. And Andrea, any thoughts too on ACE's response?
No, I think you've covered everything, Susan. I think we just need to be very aware. We know that it's been in the news, the increases of intimate partner violence, but across the country, there's been decreases in Child Protection Service referrals. And I think, you know, people just need to be aware and that there are resources out there to support families.
Thank you. And with 1 minute left, I will ask one more question. What do you think is our biggest challenge moving forward? And anyone can answer this.
I don't know how you pick just one, and there's multiple. And since my theme today has been really on the service side, one of the things that I do worry about or think about is as services start to escalate back up, as people move back into their programs, how do we health units, services really support the workforce? Because not only recognizing that workforces of nurses and family home visitors in public health are serving families with increased needs, but they themselves have also been experiencing the pandemic in their personal lives. And that any response within the workplaces has to be more than those mantras of self-care, or we're going to provide you with pizza parties and food. Those are lovely signs of recognition of work that people do during these hard times. But more importantly, how do organizations take a critical look at the organizational structures that contribute to burnout and stress, and recognize the vicarious trauma in the workforce? Because I think one of the risks is we may lose many nurses from the field, and so that's just one concern.
Thank you, Susan. So we're at time. As we wrap up today's session, I'd like to thank Andrea, Jennifer, Susan, and Karen for such excellent talks. You've really highlighted something that's been really concerning to, I think, a lot of people on this call and a lot of people I know at PHO. I would also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals. To access past presentations and view confirmed upcoming session, please visit PHO website, head to Education and Events, and click on Presentations. Lastly, you can expect to receive the brief and anonymous survey for today's session shortly. Please try to complete this to help us improve our programming. Thank you and have a wonderful day.
Thank you.
Thank you.